Hello there, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator, and I'm joined today by Dr. Aaron Boster, who will answer as many of your questions as he can within 60 minutes. I love saying that every other month. Now I'm delighted to introduce him. Dr. Boster is a board-certified neurologist specializing in multiple sclerosis and related central nervous system inflammatory disorders. He decided to become a multiple sclerosis doctor at age 12 as he watched his uncle Mark suffer from the disease in an era before MS treatment was available. Dr. Boster grew up in Columbus, Ohio, and attended undergraduate school at Oberlin College. He earned his MD at the University of Cincinnati College of Medicine and completed an internal medicine and residency in neurology internship at the University of Michigan. He then completed a 2-year fellowship in clinical neuroimmunology at Wayne State University. Since then, Dr. Boster has been intimately involved in the care of people impacted by multiple sclerosis. He has been a principal investigator in numerous clinical trials, trained numerous multiple sclerosis doctors and nurse practitioners, and published extensively in medical journals. He lectures to MS patients and provides worldwide with a mission to educate, energize, and empower people impacted by multiple sclerosis. He lives in Columbus, Ohio with his son, Maxwell. Dr. Boster, we are once again very pleased to have you join us. And
Thank you so much for having me.
I'm just going to tell everybody who has not been with us, I don't know if there's anyone that doesn't know how to do this, but I'm going to explain. If you have a question or comment, you can just ask it using the Q&A button in the app, which also allows you to send your question anonymously if you choose. You can even ask your question live by raising your hand. And to do so, you just click the raise hand button or press *9 if you're on the phone. I'll call on you, which of course at that time you'd have to unmute yourself so you can ask your question. So I'm going to say, why don't we start? Let me look to see if we have any questions, which we do have a couple in chat and a couple in. Oh, sorry. We have Quigley, S. Quigley says hello from sunny Southern Arizona. So,
howdy.
Okay, is Mavenclad best used as an exit strategy from DMTs when you reach a certain age? I read an article that it has an average of 15 years without needing a new DMT. I'm 42 years old. Did I jump the gun?
That's a really great question. So we're talking about MS disease modifying therapies, things that are intended to slow down the disease process, prevent attacks, prevent worsening on exam, prevent new spots. And Mavenclad, cladribine tablets, is an oral drug. It's a pill, and it's a real weird pill. You take a pill once a day for 5 days the first month. So you're only taking 5 pills that first month, then 5 pills the next month, and then you're done for the year. So 10 pills that first year, wait a year, 10 pills the next year. And then we don't retreat you unless you have new disease activity. And so there are people that go more than 10 years and never get retreated, which is pretty exciting. Now, the question is about where to place Mavenclad. And there's several places that you can put Mavenclad. I have used Mavenclad in 60-somethings, kind of like we're talking here about like, I don't like the term exit strategy, but sort of in that vein. I've also used it very, very early on in people that were trying to have a family. They wanted to hurry up and get treated and then they could have kids. I've also used it very successfully to escalate from other drugs when people have broken through. So do I think you're too early using Mavenclad at 42? Absolutely not. I don't think you're closing any doors. And if, God forbid, you have new disease activity, you still have every option available. So best of luck to you. I can't hear you. You're muted.
Sorry about that.
No worries.
Can folks with MS do weightlifting and build muscle the same way as those without the condition?
Yes and no. Okay, so the muscle is normal in someone with multiple sclerosis. Like there's no concern with the muscle. And there's no problem with the nerve going to the muscle. However, in some people with MS, there's damage to the brain or spinal cord So the muscle doesn't always get the message.
Mm.
You can, if you can move the limb, you can build muscle. It might be harder if you have spinal cord or brain damage because the circuitry that's running the muscle might not always listen, but you can still rebuild it. One of the best ways of getting started in a wellness program with a focus on weightlifting is to work with a physical therapist, a neurophysical therapist who can set you up for success. But the bottom line is lifting weights is a fantastic exercise for MS, and I strongly suggest that you try it.
Thank you. And Doris is asking for you to comment on the psionic neuros sleeve.
So the psionic neural sleeve is freaking amazing. Now, I don't have a relationship with the company, but I would like one. The psionic neural sleeve is really a revolutionary item that I've become increasingly excited about. It's a neoprene sleeve that goes from your hip to your toes, or actually to your ankle. Okay, so it goes along your whole leg. And here, I'll try to. And it goes on your leg, and there are 8 electrodes on your quadricep and 8 electrodes on your hamstring, 8 electrodes on your calf, and 8 electrodes on the tibialis anterior. And then it's hooked up to through Bluetooth to your smartphone. And there are programs which stimulate your muscles in the proper patterns so that your leg can move properly. So if you think about someone that has a foot drop, and you stimulate the bottom of the leg, you get the foot to come up. But what if they have a hip drop? What if their knee drops? This device helps through all the mechanics of gait. So it's very exciting in my mind. It's not free. You have to pay for it. But I have learned from patients that it seems to be affordable. You pay on a monthly fee, like a subscription, and you can cancel it, so on and so forth. I really think that it's a step forward in helping as it relates to adaptive devices. I really like it.
Thank you. Teresa's asking, what are your thoughts on the baclofen pump? I've had one for 2 years. It hasn't stopped the spasticity, as I now do Botox as well as Dantrum.
Dantrolene. So I'm biased because I manage a lot of baclofen pumps. I've published extensively on baclofen pumps. I'm like a baclofen pump guy, so I'm very, very biased. I think they're amazing. I question whether or not the person managing your pump doesn't have the chutzpah to turn it up more. All too often, I see someone who has severe spasticity, they get a pump, and the device is barely turned on, and they may be getting like 25 or 50 micrograms a day. And I think that at least among physical medicine doctors, there's a misbelief that people impacted by MS are ultra sensitive to baclofen, which is simply not true for all comers. So I think baclofen pumps are amazing devices, and I would question whether or not yours is being used aggressively enough.
Okay, thank you. Rosemary has asked, she said she's 71 years old and was diagnosed as either secondary or primary in 2022. She's currently not on a DMT because she's fearful of the PML infection, as she was positive for the JC virus. Her legs have been getting weaker because she has weak hip flexors and stiff ankles, which makes it difficult to walk. And she also has poor balance. Do you think that she would benefit by taking Aubagio or its generic?
Yes, absolutely, I do.
Perfect. And Debbie said, is there ever an opportunity for my kids to get an MRI proactively? If only I had an MRI sooner, I would have been diagnosed and treated earlier. They don't have any strong symptoms, but neither did I until I did.
So we generally do not recommend doing MRI scans on children of people impacted by MS unless they have neurological complaints, and then we most certainly image them. That stated, you might call Children's Hospital near you and ask if there's any clinical research studies with MRIs for children. Now, one thing that I want to point out is that most places in the United States anesthetize children. So they intubate them and put them under, like they're going to have a surgery to have an MRI. And so that's not a benign process. There's actually some risk associated when you have to intubate a child. So I would be even more reluctant to ask a child who doesn't have any neurological abnormalities to undergo that process. I think a good proxy for that is a careful history and helping your child understand, listen, if you ever have any weird neurological things, don't hide it. You got to tell mom and dad, or you got to tell someone so that we can look into it.
Okay. Please address not giving DMT to those in their 70s. I know you discussed that a bit before. If you have anything else to add, they don't understand it.
I don't understand it either, but I think the term is called ageism. And it's where you discriminate against someone simply because they've had more birthdays than you. And I think that a lot of doctors suffer from a misconception and they act ageist. So if you are 70 and you have neurological features that you enjoy, like swallowing or seeing or smelling or orgasming or moving your fingers or something that you like, which is driven by your nervous system, and you have MS, your immune system will attack you. And so I want to preserve the neurologic reserve. And whereas a 70-year-old is less likely statistically to have an attack, they're less likely to bounce back if they have it. And they are very likely of having progression of neurological disability. Aubagio in particular is outstanding at slowing disability progression. It's also very good at slowing brain volume loss. It's also very well tolerated. And so I think that is an outstanding option for someone who is maybe 71 years old and looking to be treated for their MS.
Thank you. Laura, I'm not quite sure of this. Maybe Dr. Boster's going to understand it better, but she said regarding Mavenclad, do I have to throw progression on my MRI, such as activity, or can I just have physical progress? I finished Mavenclad 2 years ago, turned 65, and have progression to do a third round. What do you think?
Deb, I'm having trouble understanding the question also, but let me take a crack at it. And if I misinterpret it, I apologize. The way that I'll choose to interpret this question is what needs to be done after you induce someone with Mavenclad. And it's my opinion that you still want to monitor the human, particularly if there's a discussion on the table of possible disease activity and possibly retreating them. So when I'm trying to monitor someone to see if they're doing okay, or if we're winning, or if the drug's working, or however you want to phrase it, there's really three things I look at. What they tell me, because remember that you're a you expert, so you know a lot about you, and I just have to listen. Two, what I see on exam when I run you through the MS Olympics, right? And then three, what I see on the imaging. That stated, my last comment is I do find imaging to be less useful as you get a little bit older. And so some of my patients after the age of 60, we may opt to image like every other year, but that's very individualized.
Thank you. Looking at my most recent MRI from the axial view, it seems like the half moon shaped void spaces are getting bigger. Is this a sign my DMTs aren't working?
So what we presume you're looking at is brain volume loss or atrophy or brain shrinkage. Now, everyone over the age of 18 has pre-programmed brain shrinkage on purpose. Just like our skin gets thinner as we age or we get shorter as we age, our brain gets a little bit smaller every year. In the setting of undertreated or untreated MS, brains can shrink way faster than we would like upwards of like 5 or 10 times faster. And some of the MS medicines are better at slowing brain volume loss as compared to others. So I can't tell you with authority that that means the drug's not working, but I can tell you that's concerning. And it's worth a conversation with your neurologist, in my opinion, to say, hey, does the brain volume loss bother you? How does it look compared to age match controls? And is my drug good at slowing that down, or do we need to kind of consider other things? That was a great question.
Yeah, thank you. Barbara's asking, please, let's see, what recommendations do you have for insomnia that is caused by MS lesions? I don't mean insomnia caused by things like restless leg pain, etc.
I think what they're saying is they think that because of specific brain damage, they now have insomnia. And I am not familiar with that occurring in the setting of multiple sclerosis. There are some very rare cases of an Italian family that has a weird brain problem and none of them sleep. Like the entire family, like they don't sleep. But it's a very, 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 very weird thing. And it's not something I'm familiar with in the setting of multiple sclerosis. So I'm going to have to pass on that one.
Thank you. And someone's asking, they were recently diagnosed with MS. Over the last year or so, they've noticed that their endurance has tanked. They get tired during workouts and can't go as fast or as hard as they once did. Is this an MS symptom? And if so, is there anything that they can do to improve it?
So yes, that is an MS symptom. So when we are doing a neurological assessment for MS, the so-called EDSS, which is just a fancy neurological examination, one of the things that we inquire about is difficulty with strenuous or athletic activities. So if you used to be able to run 5 miles and now you can only run 2, that is worsening. That's bad. Now, you may be more athletically inclined than like everyone else around you, but for your baseline, that's not okay. So that's not something to ignore. That is something to to face head on. And I think I would be looking at several things. I would be looking for some physical therapy, some reconditioning. I would be looking to make sure that our medicines were on point and that they were controlling the other aspects of disease. I may even be looking at like things like heat sensitivity and motor fatigue to see if we might be able to tweak that to get you out running farther and faster.
Thank you. And Bobby says that they watched your video on your YouTube page and you talked about taking a walk in the evening, but if you're less active in the evening, should you still push through it?
So first of all, thanks for watching my YouTube videos. It's always nice to hear when someone watches because when I make them, I'm just like talking into my computer. So that's really nice to hear. So thank you for that. Exercise is paramount to living your best life despite having MS. And if walking in the evenings is not in the cards, like for whatever reason, like you don't have enough energy or whatever, then maybe you could get a different exercise in, or you could do walking in the morning or the afternoon. If you only have time, like some of us, the only time that we could exercise would be in the evenings, which is not uncommon in the United States. And if that's the case, I would encourage you to try really hard to get a walk in a couple times a week because we have to keep moving. If you have MS and you don't exercise as part of your lifestyle, you'll end up more disabled as you age compared to if you didn't. And I don't want that for you. So I think walking is awesome.
I've heard Dr. Karpatkin constantly say, you want it to move, you got to move it, right?
Yeah, that's really well stated.
Yeah. So Maria says, is Kesimpta good for secondary progressive MS?
So Kesimpta is a B cell depleting medicine. So it's in the family of medicines with rituximab, Ocrevus, ufatumumab is Kesimpta, and then also we have Briumvi. So there's several medicines now that are all B cell depleters. They are amongst the most effective medicines currently FDA approved. And I think they work very, very well to treat relapsing forms of MS. So-called secondary progressive MS, I don't actually think exists, but if we're talking about someone who has relapsing form of MS and is now having some progression, I think Kesimpta is a very wonderful option.
Thank you. Kimberly said she's 63, secondary progressive, wheelchair user. She's been off DMT for 5 years due to having several exacerbations while on Ocrevus. What are her options?
So I'm presuming that the question is about options for disease-modifying therapy. And if someone truly had several attacks on Ocrevus, then that's probably not a good match for them. The good news is I count 27 different drugs to treat MS in 2024. So that's one, which means there are 26 others that we could talk about. Now, I don't have enough information here to make comments, but I definitely think we could find something.
Thank you. And will fixing my gut with a probiotic alone help my MS symptoms? Cher is asking.
It may help symptoms related to gut transit. So many people impacted by MS are either profoundly constipated or they have IBS type symptoms where they have like diarrhea, then constipation. And taking a probiotic and sometimes a prebiotic fiber can help with that. It can help in that regard directly as it relates to absorption and gut transit. Now, the question is actually a bit provocative because there is some ongoing research looking at probiotics and changing the gut microbiome to actually slow multiple sclerosis.
Hmm.
But the jury is still out on that. So I'm certainly not proposing that for a limited time only for $9.99, if you take a probiotic, it's going to slow things down. I do recommend probiotics for the gut benefits in many, many of my patients. Absolutely.
Thank you. So Susan's asking if BTK is still being investigated for primary progressive MS.
Excuse me. Yes, aggressively. So I am currently involved in one clinical trial called the Perseus trial. And this Perseus trial is looking at one of the BTK inhibitors called tolobrutinib. And in the Perseus trial, we are only enrolling people with primary progressive multiple sclerosis. And at the Boster Center for MS, we have several PPMS patients that have volunteered their bodies to participate in the Perseus trial to answer that question for you.
Thank you. And S. Quigley said that they were diagnosed with MS August 2023 with one incident in July 2023, where over 6 days they had numbness, tingling, hypersensation starting at the feet and progressively bilaterally up to their chest and hands and wrist. MRI shows one lesion at C2, C3, no additional lesions. Taking dimethyl fumarate 240 milligram 2 times a day and gabapentin 600 milligrams at night. Neuro won't classify MS category relapse remitting. Is there a chance it might not be MS, but transverse myelitis?
So first of all, S. Squiggly is kind of a cool name.
It is.
I like your name. You did a good job, but I don't have enough information. So what you describe is a high cervical transverse myelitis, but someone with MS can have transverse myelitis and someone can have transverse myelitis without having MS. So in order to answer the question, I would need to better understand your complete history and look at your MRI of your brain. So without that information, I'm unfortunately not going to be able to take that question any further.
Thank you for trying. What are your thoughts on Botox for the bladder?
Freaking awesome. So the bladder is a bag that holds urine or beer or like whatever it is that you were drinking. Okay. And its storage capacity is based on the size. So when you have MS, very commonly you can develop a spastic bladder. So the bladder goes from being this big down to like a little racquetball. So now you can hold half a Coke and you got to go pee-pee, right? Which is really, really frustrating. When you take bladder Botox, what you're doing, the urologist is snaking a tube up your hoo-ha to get into your bladder and then Botoxing the inside of the bladder and relaxing it so that it can be a normal size. It can really help people quite a bit. So I have many, many patients that benefit from bladder Botox, and I definitely think it's a powerful tool to keep in the toolbox.
Yeah, it sounds wonderful. Wow. Amy says, what do you recommend for joint pain? Now that the weather is nice, I've been running, but have pain in my ankles.
So that's not so much a MS neurology thing. That stated, I would start by trying chondroitin. I have a lot of success with patients benefiting from taking chondroitin. So that's what I would probably try.
Okay. And Karen said, I have MS and my adult daughter has been diagnosed by an ophthalmologist with convergence insufficiency, 15 cc's. She has no other symptoms. Could this be the beginning of MS? I don't want to scare her unnecessarily.
So that doesn't sound like it. I mean, but the good news is she's seeing a neuro-ophthalmologist, and they tend to be very smart women and men. And invariably, they will get MRIs of her noggin. And God forbid if she has spots, then we'll jump on top of it.
Great. Thoughts on Octave MSDA blood test and the neurofilament light chain test?
So there is a massive desire through the entire MS community to develop better biomarkers. So a biomarker is a test which teaches you about a human without actually like going inside the human, right? So today we've talked about one biomarker called the MRI, right? So the MRI is a powerful biomarker. Another biomarker would be like spinal fluid. So spinal fluid is a diagnostic biomarker. So there's a strong desire to develop a biomarker to measure how you're doing. Like, is it working? And there's the development of several blood tests with the goal of trying to figure that out. Right now, some of the most provocative data, which is also the farthest along, is looking at a blood test called neurofilament light chain. And I will tell you that it is not prime time yet because we still struggle to come up with controls. So even though it can be ordered by like a laboratory, we still struggle to figure out how to interpret that information. So I don't feel like it's prime time yet. I still think it's in the realms of research. Now, there is a for-profit company that is trying to make money, and they've developed some programs, and they are touting them as being helpful biomarkers. Now, I personally have some major concerns with their lack of scientific data supporting what they're doing. And I have some major concerns with how they bill patients for the information. And so I personally have not chosen to participate with that particular investigation. But the concept is outstanding. And conceptually, we need better biomarkers so that I can draw some blood and say, haha, we're doing good, or maybe we're not.
Thank you. And Gus said that he's read that there's a phase 1 trial for an inverse vaccine for MS. Can you comment on that?
I can only comment about the goal of the trial. So we believe that people probably have to get mono, so the kissing flu, as one of the steps to develop multiple sclerosis. So there's a theory that if you could prevent someone from contracting mono, maybe by vaccinating them before they get it, maybe then they couldn't go on to have MS, right? Now, when you talk about phase 1 trials, a phase 1 trial is where you have a concept and you're going to test it in healthy controls. So you're normally looking at like poor college kids, and you're giving them something, seeing if they blow up or not. Like you're literally looking at safety. Once they clarify in the phase 1 that it is safe amongst young, healthy controls, then they will move into the MS space. So my point in saying that is this is very, very early in human trials, but it's also very exciting.
Thank you. Can you talk about the efficacy and the safety and cancer risk of Mavenclad?
Sure. So we mentioned earlier, Mavenclad is a disease-modifying therapy, and I consider it to be a highly effective disease-modifying therapy. Specifically, I call it king of the pills because I think it's better than every other pill, and I think it's not as effective as the monoclonal antibodies. That's my opinion. It's very good at shutting down relapses, and I think it's very good at controlling new MRI lesions. I also feel that there's a huge advantage that you can see a durable effect in the absence of retreatment. As I mentioned earlier, you take 10 pills the first year, 10 pills the second year, and then you don't take it again unless, God forbid, you have disease activity. There's plenty of risks with all MS disease-modifying therapies, and Mavenclad is no exception. And so there's a very small increased risk of cancer, and the FDA, in its wisdom, recommended age-appropriate cancer screening, which means I, as an MS neurologist, am now like really competent at like when you need a mammogram and like a colonoscopy and like all of these age-appropriate things. The drug is very well tolerated. I've given it to quite a few people in my practice, and it's well tolerated. That's a really nice thing. And I think there was a third part, efficacy, safety, and then I forget the last one. I'm sorry.
Cancer risk.
Yeah, so we talked about the cancer. So I would submit that the cancer risks is increased by like maybe just over 1%, and it's screenable. And so I don't view that as a deal breaker as I'm trying to figure things out with patients and families.
Okay. And we do have a couple people who are thanking you. They've learned a lot since their diagnosis, and also that your videos are wonderful and very informative. So
Thanks, guys.
Marietta is 56 and has had MS for 10 years. She says that she's been on natizilol,
Natalizumab, Tysabri.
thank you, for 6 years with no relapses and no evidence of disease activity on annual MRIs. She's JCV and on
Negative.
interval dosing EID of every 5 weeks and 1 day per. A study showed to her, let's see.
By her MS neuro, who indicated that this will further decrease her risk if she were to turn JC virus antibody positive.
Yeah.
So can I remain on this drug with an unacceptable PML risk? Also, will Medicare cover natalizumab, Marietta in Montana? So that's a great question. So if you are JC virus antibody negative, that means that you have never been exposed to the JC virus. So if you've never been exposed to the JC virus, you can't contract PML because you can only get PML from the JC virus. So doing infusions every 5 weeks is not necessary if you're JC virus antibody negative because you don't have a risk. You know, it's not wrong, and it works just fine. So you may choose to do every 5 weeks simply because it's more convenient than getting every 4 weeks, right? If you were to convert from JC virus antibody negative to JC virus antibody positive, it doesn't mean, in my opinion, that you're required to stop the drug. It just means that we have to mitigate the risk and talk about it. And you might conceptually have a risk of a brain infection PML that might be 1,000th of a percent or 100th of a percent. And that's a very, very low risk. Now, I don't view my right as I'm allowed to tell you whether that's okay. I don't have that paternal right to inform you that you should be or not should be okay with that. I feel rather it's my ethical obligation to educate my patient about the risk and then allow them to tell me their comfort level. So I have some patients who are JC virus antibody positive, so they're at risk. And this one patient says to me, honey, when the risk is 1 in 10, let me know. Now, I want to tell you that that person is a doctor. She's very, very smart medically. And so you couldn't tell me that she doesn't understand medical risk benefit because she certainly does. I have other people that if they're JC virus antibody positive, they won't even have a conversation with me. They're so terrified. And that's okay too, because it's not about the science or the stats. It's about your level of comfort. So what I'm reading here sounds like you keep on keeping on for a very, very long time, sister. And I am delighted to hear about how you're doing on that scan or on your scans and how you're doing clinically. Whether or not it'll be approved by Medicare, it is approved by Medicare, but you want to have a secondary insurance because the Medicare will pick up 80% and then you have to pick up 20%. And because our government is so awesome, the government disallows patient assistance if you use government insurance. So it behooves you, in my opinion, to get a secondary insurance to cover that other 20%. And then that will make it absolutely feasible.
Smart, good advice. Bobby said they started OKIS 7 months ago, but really doesn't feel a lot better. Should they talk with their doctor to try something else? And that person goes to Ohio Health and they all know you and say good things.
Well, come on over and visit me. We're not that far away from that building.
Nice.
When you have 3 children and you start oral birth control pills, you still have 3 children, right? The 3 children don't go away just because you start birth control. And if you're curious why you're on birth control, go hang out with your 3 kids. I'm making a joke, but it's simply to share with you that you take a birth control pill to prevent an unplanned event, right? You got 3 planned events. You don't need an unplanned one. And taking an MS disease modifying therapy, and in this example, OKIS, is not going to remove the neurological brain and spinal cord damage that's already been done. So if you have suffered an optic neuritis and you can't see in your left eye very well, taking a DMT is not to give you back the sight, it's to prevent the other eye from going blind. The disease-modifying therapies don't make you feel better. They preserve your brain so that you can continue to be awesome 20, 30, 40 years from now. We have to treat the MS with the medicine like OKIS or something else. And then in addition to that, we have to treat symptoms to improve the quality of your life. So come over to the Boster Center, 614-304-3444, and we'll help take care of you.
Thank you. Someone said that recently they had their reflexes tested by their neurologist. When the neurologist hit their knees, they could barely feel it, and their feet didn't react. So can you explain what really happened? What does that mean?
Sure. So when you're doing a neurological test, like when the neurologist is having you do all the things, what they're doing is they're testing different neurological systems. So there's it's kind of like I'm going to use an analogy. When your car makes a funny noise and you bring it to a mechanic, the mechanic does a diagnostic evaluation. So they'll check out like the brake system to figure out if that's the problem. And if it's not, then they'll check out like the transmission and they'll see if that's the problem. And they keep systematically going through the different systems in the car until they find out what's wrong. The neurological examination is trying to do that with a human's nervous system. So when we have a reflex hammer and we smack your reflex, what we're doing is we're actually testing a part of your spinal cord. So because my foot is way down there and my arm's up here, I'll just use my arm as an example because I'm not that flexible, but imagine that I'm hitting my knee, okay? So when I smack the tendon, it sends a message up the nerve to my spinal cord, which sends a message back and makes my arm contract a little bit. That's a reflex. It's not voluntary. It's something that your nervous system is hardwired to do. And when the neurologist is smacking all the different reflexes, the goal is not to see if one is there or not. The goal is to see how much of it's there. Is it overly active, which we see in MS, which is actually not good. So if I smack your reflex and I get a really robust response, that actually teaches us that there's damage to the brain and spinal cord at whatever level that is. So at your knee, that's the L4 level. At your elbow here, that's the C5, 6 level, right? So the neurologist is learning things about the levels of your spinal cord. If you felt it or didn't feel it is not relevant to that particular test. And the amount of movement is relevant. And so it might mean that you have suppressed reflexes. Why? I don't know. We'd have to look. You can have suppressed reflexes because of a big body habitus. You can have suppressed reflexes because of diabetes. There's a host of things. And so that's just one diagnostic test, which the neurologist will use along with a bunch of other information then to make a decision about how you're doing.
Thank you. Gillian is asking, how do I know when to change my DMT? My last MRI didn't show any progress. I've been on interferon since my relapse remitting MS in 2013. My doctor is suggesting that I change to ensure no progress.
So generally speaking, there's 5 things that could happen which would make me want to switch your drug, or at least talk about it. If you have an attack on a drug, then we should talk about switching. If you have new MRI spots on a drug, we should talk about switching. If your exam's getting worse on a drug, we should talk about switching. If the drug is not tolerated, we should talk about switching. And if the drug is no longer safe, we should talk about switching. There is a 6th category which applies in this situation. If we've developed drugs that are categorically better than the one that you're on, we can get an upgrade. So interferon beta products were the bee's knees in the 1990s. All right, like when we were popping our collar and ducking our jeans and wearing ripped jeans and listening to hip hop and whatnot. And they, at the time, were some of the very best medicines out there. And they are now, 30 some years later, amongst the very weakest medicines. And in particular, they're not good at slowing progression of neurological disability. So if I have someone on an interferon, I'm oftentimes desirous of switching them to something that offers more. I'll give you an example. This cell phone is more than just a telephone. Like, it's a computer. It can translate Greek It can do advanced mathematics. I can play video games. I can even do like Star Trek type stuff where like I can look at it and see you and we can have a conversation. The phone that I had in the 90s worked, right? It was attached to the wall and I had a rotary thing and I would talk on it and then I would hang up and it worked fine. But I don't have that anymore. I have this instead because this is an advancement in technology. Just like the newer MS medicines are, in my opinion, an advancement in technology from the interferons.
Great answer. How do you feel about doing steroid infusions for MS flare-ups, and how many days is standard procedure?
So if somebody has a new MS relapse, then we want to hasten the recovery and get them back in the game and quell the inflammation. And the number one or the first way that we do that is by giving high-dose corticosteroids. So you may have heard of IV solumedrol. So that's a bag of this steroid that we run into your body through your vein. Or we can do high-dose oral steroid. There's a host of ways of getting steroids. And steroids are the first thing to help you recover. And so if you're having an attack, I'm going to offer you steroids, and then you'll let me know whether you're willing to take them or not. Now, as far as the number of days, it really depends on the doctor and how they were trained. So for example, I was trained to give 5 days. So I'm going to go for broke. Some doctors are more comfortable with 3 days. And I don't think that there's any, actually, I know that there isn't any science that proves that one is superior to the other. The goal is to quell inflammation adequately to make them get better. So sometimes if I start someone on steroids and 3 days in, they're killing it and doing better, we'll stop. And if not, we'll continue for 2 more.
Nice. Let's see. I was diagnosed last year with primary progressive at age 62. I was started on OKIS. Everything I am reading is suggesting I am too old for OKIS. What do you think? I cannot find a lot of info on primary progressive.
So OKIS is FDA approved and EMA approved for PPMS based on a trial called the Oratorio trial. So I would read the Oratorio trial, which demonstrates that people with PPMS that took OKIS slowed disability by 20% compared to placebo and they slowed their MRI by 20%, the brain volume loss. Very, very impressive. Disability was decreased by 24%, but who's counting, right? So we didn't study people in their 60s, but that doesn't mean that it doesn't help people in their 60s, because it does. So I 100% would continue to treat you. I can tell you time and time again in my own clinic, when people have opted to come off of a medicine, I watch them progress and then we put them back on. And so I would keep on keeping on without question.
Okay. And what is the average time patients stay on Zosia, and would you escalate to a stronger DMT if required?
So I'm biased because I don't think Zosia is an awesome drug, which it doesn't mean it's an awesome drug. It just means I don't like it. All right. So Gilenya is the parent compound, and now there's Zosia, Mayzent, and Ponvory, which are all second generation Me Too drugs. And the whole class of pills, the S1P1 receptors, aren't effective enough, in my opinion. So I have issues with them because I don't think they do a good job of slowing disability progression. Their ability to slow disability is not rock star status. That stated, there are plenty of doctors that like the drug, and they can probably defend themselves as to why. I have a low threshold to escalate beyond an S1P1 receptor because I'm looking for better control of progression of disability. And again, that's just my opinion. It does not make me right. It just makes me really opinionated.
Laura wants to know what your thoughts are on Copaxone.
So Copaxone was developed in the mid-90s. It's an injection and it's 4 amino acids in a random order, G, L, A, and T. So that's why the drug, the real name is glatiramer. And glatiramer acetate, you inject it under your skin, and you basically show your immune system something that looks like myelin. So you're teaching the immune system, hey, this is myelin. And then the next day, it's myelin. And the next day, it's myelin. And you just keep showing the immune system its target. And what happens when the immune system sees the actual myelin, it's like, I saw that yesterday. And instead of attacking it, it kind of is like not interested. Now, Copaxone is very, very safe, like extremely safe. Like we can give it to people when they're pregnant. We give it to people that have MS and cancer, MS and HIV. I mean, you can give Copaxone. It's very, very safe, but it's also not very effective. Now, coming up through the ranks, I was trained by some men that used Copaxone a lot. And so when I started my clinical practice, I put a lot of people on Copaxone. But it's not a drug that I use very much anymore, simply because we now have drugs that are superior to it in their ability to control the disease.
I know somebody has their hand up and I'm having difficulty getting to that. So until I can figure that out, let's go to the next one, which is Tanya asking, do you think that intermittent fasting helps MS?
Yeah, I do. So if you are overweight and you have a weak leg, that's a lot of extra weight on that weak leg. If you lose that weight, there's less weight walking on a weak leg. You're going to walk better. It's just physics. And one of the best ways to help control weight is to do what's called timed eating, where you have a window when you eat and a window when you burn the calories that you were eating earlier. Now, I have a personal interest in intermittent fasting. I participate in intermittent fasting. And I've made many, many YouTube videos on the topic. And I've made YouTube videos discussing that it is safe for people with MS to do intermittent fasting. So if you'd like more information on that, definitely check that out on my YouTube channel. But suffice to say that I think it's a beautiful option. And I want to tell you one quick story. A young man that I take care of who has severe multiple sclerosis. So he can't move his arms and his legs. He can move one arm a little, but he really can't move very much. And as you can only imagine, he became very overweight because he can't move. He started intermittent fasting and lost 40 pounds. He stopped having decubitus ulcers. He's not having the same degree of spasticity. It's a really big deal for him and his family. And that was accomplished through his hard work with intermittent fasting. So I think it's good stuff. Now, of course, you want to talk to your doctor before you change anything as severe as when you eat, but I find it to be a very powerful tool. And I talk to my patients about it a lot.
Nice. Are you able to tell how long a person has had MS by their MRI?
No.
Okay. Let's see. Do you see anyone with their, oh, sorry, let's see. I'm getting my thoracic spine, cervical spine, and brain MRI in consecutive weeks, each with contrast. Is this too much? Will this much contrast be harmful to me?
So two things. So no, it's probably just fine. All right. Two things that I want to think about. Number one is, do you have normal kidney function? So as long as you have normal kidney function, you should have no trouble peeing out all the contrast agent. Also, as long as the center is using macrocyclic contrast, there's two kinds of contrast. There's linear contrast, which is bad. You don't want that. And then there's macrocyclic molecules that are not stored in the body and easily gotten rid of. And I'm not aware of any centers in the United States that use linear molecules anymore. They all use macrocyclic molecules, which are safe. And so I do not think that's too much. I would vote to go ahead and do that with the contrast. That's my opinion.
Thank you. And I did find LaShawn. I'm going to allow you to talk. So if you would go ahead and ask your question, you have to unmute yourself.
Howdy.
Hi, can you hear me?
Yes, ma'am.
Okay, so I am 40 years old. I was diagnosed with MS when I was 24, and I take this pill daily. It's a little blue pill. I forgot the name. Do you think I should switch um to get it like intravenously, or should I stay on the pill?
It depends on what the blue pill is. You know what's funny? Doctors don't know the colors of pills. Like we learn about medicines and we learn like what they do and how they work and all the side effects, but we don't know what they look like. So very commonly someone will say it's a blue round pill, and I don't know what that one is. So I would definitely figure out what the pill is and then talk to your neurologist about other options.
Okay, thank you.
No problem. I'm sorry I don't know the color.
Thanks, LaShawn. Okay, how important is the Abagio black box warning about liver failure? Is it a very small percentage of people?
So there's a story behind this. Abagio was developed based on an old medicine called Arava. And Arava is used to treat a disease called rheumatoid arthritis. And when you give Arava for rheumatoid arthritis, you always give it along with methotrexate. Both drugs are liver toxic. And so there's a bunch of rules about using Arava safely, with checking liver enzymes every month for 6 months. When the manufacturer of Abagio developed Abagio, they literally copy and pasted Arava's package insert. And they adopted all the safety monitoring for Abagio just like Arava. Even though we only give Abagio by itself, we never give it with methotrexate. So in clinical practice, rarely it can elevate your liver enzymes. Now, when it does, it typically skyrockets, and it'll normally do it well within the first 6 months. So we want to check liver enzymes before you start the drug, along with all the other safety labs. And then we want to check a liver enzyme called the ALT, which is just one blood test, every month for the first 6 months. Because if you're going to spike your liver enzymes, you're going to do it within that time frame. Now, I've had patients where that happened, and honestly, it's not a big deal. We stop the medicine, it goes back down. And then we just pick a different medicine. But that monitoring in the first 6 months is important because we want to catch a liver problem if we're seeing it so that we can stop and keep your liver safe.
So this must, I'm sure Angie means an MRI, but it says my March 2024 showed a white spot on my brain that was not present on my last MRI done in November 2022. My doctor thinks it's an old stroke. Do you think it's a stroke? And how can I prevent having another stroke?
Not enough information for me to comment. When you get an MRI and there's a white spot, it doesn't come with a label. Like there's no arrow telling you the answer. And so what the radiologist and the neurologist are trained to do is to look at the size, the shape, the location, and the behavior when we give contrast to try to sort out what it is. If you had a stroke, there's a host of things that we can do called secondary prevention. Like we can take an aspirin, we can take a cholesterol medicine, and we can commit to a lifestyle of exercise. We can control high blood pressure and diabetes and high cholesterol and minimize the risk of a second stroke.
Thank you. Can NFL blood test effectively diagnose MS?
No, it cannot diagnose. The reason it can't diagnose MS is NFL goes up with any form of brain damage. So if you got socked in the head and had a traumatic brain injury, NFL would go up. If you had a brain tumor, NFL goes up. If you have ALS, it goes up. So it's not unique to MS, and therefore we can't use it to diagnose the disease. Our hope is that we can use it to monitor the disease after we know what you have.
Great. And what is your opinion on stem cell therapy?
So I have several YouTube videos on the topic, but I'll give you my skinny opinion here. Stem cell transplantation is not a drug, it's a procedure, okay? And it's a very, very aggressive procedure. What you do is you take someone's stem cells out of their body and you put them on ice, and then you murder the human being. You give them lethal doses of chemotherapy and you permanently destroy their bone marrow. So now they have no immune system, and if they get the common cold, they're going to die. But before they die, you give them back their stem cells, and removing the immune system helps slow down an autoimmune disease. And the stem cells, they actually don't help MS, they just prevent you from dying. Stem cell transplantation is not a cure. I've participated in many stem cell transplants. I shouldn't say many, like I guess I did 4 in a research trial, and I take care of 5 patients right now that have all gone through stem cell transplantation. It's not a cure. It's something which is appropriate in very severe cases of MS. And in Europe, particularly in the EU, in Great Britain, you can get a stem cell transplant if your MS is deemed to be aggressive. That's available through the NHS system. Here in the United States, however, it's still not available outside of research. Now, one last comment. I want you to be very, very cautious about something called stem cell tourism, where you can travel to an exotic location like India or Russia or Chicago and pay some guy a bunch of money and they'll swap out your bone marrow. And I want you to be very cautious doing that because there's some intrinsic risks in that.
Thank you. Somebody says that they were diagnosed with primary progressive at age 60 and they suffered permanent nerve damage from the antibiotic Cipro 6 years ago, but learned to live with it. Then they received a tetanus shot, and that's when they developed all the current MS symptoms. Do you think it's possible to get MS from a tetanus shot?
No.
Okay, that was easy. What's your opinion of Empira for balance and walking?
Empira, or 4-aminopyridine, is a drug that doesn't slow down MS. It treats a very particular symptom. Many people with MS, when their bodies get overheated, like either because they're like jogging or because it's hot outside, it causes their core temperature to rise and they short circuit their nervous system. So someone who used to have an optic neuritis years ago goes out in the heat and they go blind as long as they're overheated. And as soon as the temperature cools back down, then they can see again, right? It turns out that there's a couple scientific reasons why that occurs, and Empira treats some of them. So Empira is a pill taken twice a day. Unfortunately, only about 1/3 of patients respond. I will give it to a patient for about 2 months before I decide if it seems to be working, because it can take like 6 weeks for it to start working. And what it does is it buttresses against heat sensitivity. So the way that we tested an Empira was walking speed, because that's cheap and easy, but it will treat anything that is heat sensitive. So to your question, sometimes I have patients that they can't walk, they're in a wheelchair, but their core is not strong. And when they're overheated, they kind of slump. And when they take Empira, they can sit upright. And I'll tell you one last story, something which makes me smile every time I think about it. Years and years ago, I had put a patient of mine on Empira. And this was a follow-up visit, and I'm talking to him and his wife, and we have a very nice visit. And as I get ready to leave, literally hand on the doorknob, the wife says, "Oh, Dr. B, I forgot. You can never take away his Empira." And I said, "Okay." And she said, no, I don't think you heard me. You can never take away his Empira." I said, "Okay." So I sat back down. I said, "Okay, explain this to me." My patient has heat-induced erectile dysfunction. So when his body gets overheated, he can't maintain an erection, which is kind of counterpoint to like trying to have intercourse. And that started when he was 18, and she's been with him since they were teenagers. She said, "Dr. B, when he takes the Empira, he's 18 again." So it actually treated his heat-induced erectile dysfunction. Now, I have been asking patients about that specific thing for like the last 10 years, and nobody else has told me that's true, but I still am asking.
Okay, and this is by S. Quigley again, who's saying, "I'm sorry, but my neuro just doesn't answer questions." So that's why he's asking all these. With an MS diagnosis, should certain vaccines be avoided, especially for international travel?
So this is a really great topic. I was taught incorrectly that the only vaccine that really, really is dangerous is yellow fever. So I used to allow people to get any of the vaccines really except yellow fever if it was necessary. However, I about a year or two ago, I went down to South America and I was doing a series of lectures to about 100 South American MS neurologists. We were all having conversations. And I asked them, because yellow fever is endemic in South America, so they have yellow fever in South America. And every single one of them, without exception, immunizes all of their patients. None of them have seen it trigger an attack. And when I shared my theoretical concerns, they laughed and said, "You've obviously never seen yellow fever. It's a severe disease." And so at the end of the day, if you're going to Ghana or if you're going to Zimbabwe or someplace, you're going to get a list of what the vaccines are required, and you'll talk to your neurologist about it. But over the years, I have become more and more comfortable with people receiving those vaccines for their safety.
And is it okay to push through walking and exercising even longer than you would normally do if the only thing you feel is mental and cognitive fatigue?
Yes. So I would like you to use the day after your exercise as the metric for how it went. Sometimes when you're exercising, you can do all the things. You're having the best day ever, the stars and the sun are aligned, and boy, you can just really kill it in the gym. And then the next day you're in bed. So that's not good. So I want you to use the day afterwards as your metric for if you overdid it. If you're exercising and starting to get like some cog fog, but you're not at risk of falling and you're not at risk of being injured, keep on keeping on. I'll give you a quick example. A patient of mine who has an addiction that I can't solve for running, and she likes running even though I think that's gross. And she runs marathons. So she lives in Chicago and she runs Chicago Marathon every year. And she stopped running because the MS made her right leg go numb at mile 3. And she was very distraught because she's a runner. Once I educated her that you don't cause damage when your body gets overheated, it just gets numb, she said, to heck with it. And she now simply drops her head enough that she can see her foot as she's running. She has run entire marathons with her right leg completely numb, can't feel it at all. As soon as her body closes back down, everything comes back. And I have a picture of her on my wall in my office.
Wow. I want her in my office. Send me a copy. Barbara said, can you explain the JC virus? I have now tested positive. I know it is accidentally an effect of Gilenia.
So JC virus is a little tiny polyoma virus that half of adults over the age of 30 have been exposed to. And our bodies beat the hay out of it every day. It's irrelevant. The only time that the JC virus can hurt us is if something goofy happens, which prevents our brain from being surveyed by our immune system. So in the 80s, we saw a bunch of PML infection in the setting of HIV, where someone lost their entire immune system, and then the JC virus got in their brain and caused PML. In the setting of receiving Tysabri, one of the MS medicines, if you're JC virus antibody positive, there's a very small risk of PML. And a couple of the other MS medicines have even smaller risks of PML. To be blunt, we spend way too much time nerding out about the JC virus and not enough time concerned about trying to nerd out about controlling MS. That's my opinion. I'm not trying to suggest that you should subject yourself to crazy infections, but I am much more worried about controlling undertreated MS than I am about 0.001% risk of an infection.
Great.
Let's take one more question, and then I'm going to have to eat some dinner.
Ask if we could do one more question. So this is an interesting one. Debbie said, is not being able to finish a sneeze potentially an MS symptom? I have the wind up, but I can rarely actually sneeze.
No. Let's do one more question. That was too quick.
That was too easy, huh? In mid-60s with 30 years of MS, are the highest efficacy DMTs not as effective or safe for me at this stage?
So the real answer is we're not testing drugs in 60-year-olds. Okay, so the real answer is we don't have data. Anecdotally, yes, they are still very effective, particularly the newer MS medicines. The safety profile is really specifically related to you. So as a human gets older chronologically, their immune system can quiet down, particularly in the 70s and 80s. But I still think that there's ample MS disease modifying therapies where the risk benefit can work to our favor. And so really the game, and I do not mean haha funny game, but the game of sorts is to try to figure out if this is the right fit for you, considering what efficacy we're going to get and what safety we have to contend with.
Thank you, thank you. And that does bring us to the end of our time. If you've missed any part of this conference, it has been recorded and will be available through the MS Focus Facebook and YouTube channels. Reply to your registration email for information on how to access recordings or sign up for our newsletter to learn about upcoming events. Dr. Boster does this every other month for us. So for those of you that we haven't gotten to your questions, I'm sorry. Please come back next time and he'll be able to get to them.
I'll try to go faster.
You couldn't go any faster. Our next teleconference will be next Thursday afternoon, April 25th at 4:00 p.m. Eastern. Nicole Goebel, who's the Director of Community Initiatives Caregiver Action Network, will be presenting, and she's going to be speaking about better communication for those living with MS and their care partners. As you leave the conference today, a survey will appear on your screen. We ask that you just take a moment to give us your feedback on the program and on your suggestions for any future topics that are meaningful to you. Our sincere thanks to all of our attendees for your participation, and especially to our favorite Dr. Boster for sharing his time, knowledge, and one-of-a-kind personality with all of us. Have a wonderful evening, everyone, and I hope to see you again next time. Bye.
Take care, everyone. Be safe.
Thanks.